Uh, Good afternoon, everyone. Assalamu alaikum. My name is Abdul Majid Zubaydi, intervention cardiologist from Abu Dhabi. I have the pleasure and honor to help in moderating this live case session at the Gulf Intervention Society annual meeting. The live case today will be transmitted from one of the great centers in France. We have Dr. Lafont from Pompidou Hospital, University of Paris, and his team. He will be introducing the team shortly. Dr. Lafont will entertain us with a percutaneous aortic valve case. So we're looking towards the case. We're very fortunate today to have an outstanding panelist and discussant for this session. Our panelists are experienced intervention cardiologists from the region. We have Dr. Hussam Noor from Mohammed bin Khalifa Cardiac Center in Bahrain. We have Dr. Ziad Ghazal, Professor of Medicine and Intervention Cardiologist at the American University of Beirut, Faculty of Medicine and Medical Center. And also we have Dr. Saleh Shalash from Saudi Arabia, who's a consultant cardiologist at King Fahd Medical City. So we're not going to spend a lot of time on the introduction. I think we'll leave the floor for Dr. Lafont and his team to present the case and also introduce the team before that. Dr. Lafont, the floor is yours.
Okay. Good afternoon, everyone. I guess it is good afternoon for you. I'm happy to share this session with you. And I'm presenting my team, Dr. Shamandi and Dr. Lotfi, cardiac surgeon. The patient is under sedation. We stopped general anesthesia for more than 90% of the cases, in fact 6 years ago. And thanks of the contribution of the anesthesiologist, Dr. Yves Gallet. And we have so the privilege to work with nurses, Joanne, Benedict and Stéphane. Il arrive ce ballon. So while I speak with you, in fact, I am preparing the dilation of the patient. And in fact, if you can show the... Okay, we will show you just the pre-dilation, and then we will... on est un peu obligé, non? Ok, can you show... Alors, donc, je vais le ressortir, le ballon, pour pas... Bon. Ok, c'est bon. Moi, j'ai bien envie de foutre un des îles à 18 French, je veux dire. Ah bon? Okay, so it's about 81-year-old gentleman having for a major disease, prostate cancer, which was treated by surgery and immunotherapy. And he got, in fact, in November, coronary angiogram for acute coronary syndromes, and he was stented on the RCA. And in fact, he arrived in a kind of emergency. Next slide, please. Next. Merci. For syncopa, it was a BAV 3, and he got a double chamber. Can you go back to the last slide? Qu'est-ce qu'il fait ce con? Merci. So in fact, at the emergency, in fact, he was considered as aortic stenosis, very tight stenosis, with an echo good ejection fraction, 65%. The Vmax was 4.8 meters per second, and the mean gradient was 67 millimeter of mercury, and the area, absolute area, was 0.63, which is in fact less than 30 square centimeter per square meter. Basically, he has still a systolic pulmonary artery of 57 millimeter of mercury, and he has a strong suspicion of a bicuspid valve, very highly calcified. So this is a challenge. And he has a very big annulus, which is in fact 30 millimeter, which means that we are off-label. But since it is so calcified, we consider that we will be able to keep the valve inside the annulus. Next slide, please. Il n'y a pas de conneries là. So here you can see, in fact, the scanner, the CT scan, the reconstruction 3D. In fact, based on the next, please. Yes, as you can see here, there is no much calcification. There was a stenosis on the right iliac. And in fact, there is also a stenosis on the left iliac, which gave us some problems. But right now, we have space to go for it. We consider that we still the approach of femoral artery, which is still 80% in our institution. We have a very good surgical team, which is very skilled to go to the carotid artery. And next, please. Next slide. Here you can see this is really looking like this is a Freeman-Sheo system. We are just in a different orientation to having the annulus, and you can see that there is a typical bicuspid aspect. Please, next. Next. Okay, next one. Sizing, so it's very important, and the size, as you can see, is very high. In fact, we have around 30 millimeter and 29. So we have to choose a very big size of the core valve. Next. Regarding the distance between the coronary ostia and the annulus, which are fine on the left and the right coronary. This is very important. You can see the stent on the right coronary ostium. Next. And here you can see that we are really fighting with a tough case of bicuspid plus a very high level of calcification. And we considered we could discuss with the audience whether they should go directly or should go via a pre-dilation. Is there a possibility to discuss with the audience or with the panel? Next.
Yes.
Next. I think this is the last one. Okay.
Yes.
Okay. We can go back to the video.
So obviously, I mean, in most cases, whether you use balloon expandable or self-expanding TAVR stent, you would need to pre-dilate with this much of calcium, especially if it's self-expanding. I would start with pre-dilatation.
Pre-dilation in our institution is less than 10%. In fact, it is really less than 10%. It's very rare, but this type less than 10%, 10.
Okay, 10%.
On se fait
yes.
Juste un petit pchit pour voir si on est bien dessus.
So how do you decide when to pre-dilate and when not to pre-dilate?
Did you see the amount of calcification and the fact
yes,
that the culture are totally so it's very high. So we have a high, and it's not very good, especially where on a bicuspid, which is not very comfortable situation. And having said all that together, even if we don't do it very regularly, less than 1 out of 10 patients, we consider that in that case, it is mandatory. Où est-ce que je suis là?
Would your approach, Ziad, be different if it's a localized calcification as compared to symmetrical
test.
distribution of the calcium?
That's a good point, Abdelmajid, but we end up, I mean, if really the calcium is light, which is not common to see with these type of valves, then you could do without pre-dilatation. Sometimes you do want to reduce the chance of instrumentation and reducing the chance of embolization to not pre-dilating, especially that we rarely use carotid protection device. But most of the time we do pre-dilate.
Okay, is everybody agreeing for the dilation?
Yes.
Yes, we do.
Okay, so we dilate.
The pre-dilation, Dr. Lafont, we have a question here on the on that stent we saw on the CT. The stent protruding out of the in the ostium, the left or the right coronary artery. Would you protect that stent?
In fact, the stent is on the CT. We did not see it so much protruding.
I think he had generous sinuses, so I think the stent will be fine. How big is the pre-dilatation balloon?
How big is? Can you repeat your question, please?
Balloon, what size is it?
Oh, the pre-dilatation was 22 millimeters. We do not want to break the annulus. We are on a biker speed, so we consider that it is... Attends, il faut que j'élargisse un tout petit peu mon machin. Vas-y, vas-y. OK. Non, je suis dedans. Hein. So, we didn't want to break the annulus, and we consider that the core valve will do the job, and if necessary, then we will have to post-dilate. It is very rare to see such a big piece of calcium. This is a stone, in fact. Bon, alors là,
excellent choice. I think personally we would have done the same thing. We would have chosen an undersized balloon, and for this kind of valve, we will definitely dilate. And I think the RCA stent will not be affected.
Dr. Lafont, when do you consider using an embolic protection device? In your practice?
In theory, this is a very good idea. Practically, I mean, we never use it, in fact. And we have got really very, very rare stroke. Okay, we did not induce so much aortic regurgitation, and now we will put the valve. Je pense qu'il faut peut-être que l'on pense à élargir. Tiens, Mohamed, est-ce que tu peux te mettre un? On va essayer.
And what kind of wire do you have, Dr. Lafont?
Oh, it's an Amplatz super stiff Boston. Est-ce que tu peux me mettre un petit bout de truc parce que c'est... Non, c'est mon masque que j'ai l'air... C'est de la merde, ces masques. Okay, so it's a Boston super stiff. It is... we do it manually. This is something that we use very, very standard on the routine way.
Okay, alors, so you don't necessarily go to pre-shaped wires such as the...
Yes, we pre-shape, in fact. We like to pre-shape. We like very much, especially with a small woman, with very small LV. Alors, Mohamed, il faut que tu te mettes en face, parce que là, ça va être absolument critique. On va très bien le faire. Hein. LR.
And I do want to ask you another question as you're proceeding. Now that the patient has a permanent pacemaker, does it make you feel a little bit more at ease in terms of the depth of the prosthesis?
That's a very good point.
Does it matter?
But in fact, when we got such a calcification, in fact, in my experience, when the valves are very, very calcified, usually paradoxically, we do not get so much trouble. So we are retrieving the sheaths, the 14 sheaths that we used, and we had some difficulties at the entrance of the groin. Ok. Alors, tu l'as? Vas-y, parce que là, ça va saigner la rage. La valve, elle est là? Parfait.
Okay.
This patient got a biventricular pacing, I guess, found before, right?
Vous pouvez filmer, hein, si vous voulez,
Yeah,
l'écran.
so they paced him when he
Mettez
came in
l'écran
with
parce que là-
syncope, it seems like.
Right.
So you're using a 34 valve.
Saleh, so
34, yes.
34 valve.
Là, on se met
presented with the
sous
complete
Scopie.
heart block.
Et on se met...
C'est le plus petit.
Pardon?
C'est le champ le plus petit.
Non, tu peux lâcher, s'il te plaît. Fais-moi un tout petit point fixe sur le... Ah, Dieu soit loué. Bon. Vous voyez, c'est le moment un petit peu douloureux, monsieur. On passe la valve et comme vous êtes un petit peu enrobé, I speak with the patient because...
Yeah.
ouais,
Ah,
bah, vous avez été remarquablement sédaté. So
Do you
c'est
still
normal que vous sentiez un
check
petit
the
peu.
fluoroscopy of the valve outside the body or not necessarily?
Oui, mais ça c'est normal parce que tout à l'heure c'était la répétition générale. Ok, petit point, voilà, point fixe. Voilà, là je suis dedans. Impeccable. Qu'est-ce qu'on se met comme...
C'est l'impédance qu'on avait au départ.
Ok.
So what view are you going
On
to
se met en 22.
Restez en scopie, s'il te plaît.
Petit pchit, s'il te plaît, Mohamed.
Vas-y, tu vas faire le test.
Ouais, je suis pas du tout au bon endroit.
We're trying to understand the view.
Oui, on va rééquilibrer, mais avant... Attends. Tiens, remonte-moi où je suis. I reposition my pigtail. On est presque bien là, test. Je suis pas mal là. Bon, c'est drôle de bicuspide. Hein. Bon,
Looks
on se met un
good.
peu plus de... Oui,
the wire seems deep in the
un peu plus de
ventricle,
caudal.
perhaps.
Ouais, c'est pas mal
Maybe
ça,
it should
non?
be pulled back.
Non? On est un peu bas.
The wire is so deep.
No, don't worry, it's deep, yes. La queue de cochon.
Elle est haute.
Est-ce qu'on peut baisser un petit peu la lumière, s'il vous plaît, ou on est déjà au maximum? Test. Ouais, on n'est pas du tout au bon endroit. Je crois que je veux rien savoir, cette connasse.
Ok.
Voilà.
C'est bon.
Test.
Parfait. Je
Ouais.
pense qu'on peut commencer là.
Ouais, ok.
Ouais, ok. Bon, tu stimules à 100, s'il te plaît.
On n'a pas une excellente pression, hein.
Je pense qu'il a une IA. Hein. Parfait. Test. Ok. Test.
Test.
C'est bien, elle est bien.
Okay, so now we are about to
Ok, arrête la steam.
stop la steam. Vas-y, monte encore un peu, ouvre encore un peu.
Ouais, c'est bon, il a l'impression. Mais il a l'impression.
Bon, je retire un peu mon guide.
Bon, j'affiche.
Marche la steam ou pas
Non, le steam.
On a une pression un peu basse. Hein, Ben là, on est quasiment ouvert. Hein. La queue de cochon, elle s'est complètement barrée.
Bon,
Vas-y,
c'est
test, queue de cochon. Alors, on filme. Cinéma.
Vas-y, injecte.
Non, mais attends, il faut qu'on se concentre. Tu injectes quand je te le dis, ok? Feu. Parfait.
Un peu basse de l'autre côté.
Ouais, mais... Je veux dire, on est... Bon, tu veux que je la...
Bon, là, on peut rien faire, ça, il faut la capturer. Ça.
Ouais, il n'a pas une très bonne pression. Ok, you are still with us?
Yes.
Hello? Il n'y a plus de son. Ok. So, what do you think about the positioning of the valve? We discussed
Can you
about the
replay
fact
the
that it
last
should
one?
be...
Can you replay the scene?
Yes.
Oui, celle-là.
Yes.
We are a little deep,
Little
but
low.
the valve will move on the left.
It seems appropriate. I think we will. Normally we would accept it. It's on the lower side, but I think this patient already has a pacemaker. I think we would deploy it, and I think the regurgitation is not
La pression est
PVL.
pas mauvaise, hein?
Like I think you have it. I think the regurgitation will improve after you full deployment.
You will pull the wire back before
Qu'est-ce qu'on fait là?
full deployment, correct?
Elle est un peu basse.
Ouais, un peu basse, mais
Et elle est pas très bien ouverte. Mais bon, on essaie de la repositionner. Ah voilà, vous êtes en train de sortir le guide.
non, mais je suis pas en train de sortir le guide. Tu me disais que le guide était trop loin.
Non, là, il est pas bien.
On respire à fond, bien à fond, Bon, il faut qu'on prenne une décision. Soit on la remet, soit on la remet pas. Moi, je pense qu'on a une bonne pression. Hein? Non, il n'y a rien. Il n'y a pas de drogue Ouais. Ouais. Si, là, il s'accélère un peu. Là, il est boosté. Là. Bon.
Testez mais pas, hein.
On refait une fuite.
So Salih, it's deep here.
I think the valve is on the lower side,
on la remet?
but I think I would take it. I think the initial positioning
On la remet un peu plus haut.
was a bit too low, but I think it's acceptable. I think once they deploy the valve fully, they will not have.
En fait, la remballe pas, je vais essayer de la
high degree of
remonter.
PVL
Et toi,
that's
Mohamed, quand je te demande
required.
feu, tu...
Elle n'a pas de pression, je suis obligé de...
Vas-y.
It seems
Voilà,
that he's
c'est bon.
The resheathing, yeah.
Very hearing, yes.
Then, Majid, do you think it's time to
test.
just discuss in terms with the cusp overlap view? And now this is not an issue in this case because there's a pacemaker,
Qu'est-ce qu'il y a?
Là, on est remonté.
but especially with self-expanding
Je vais me foutre cette putain de son de
TAVI
l'histoire.
valves, the cusp overlap view is pretty good to implant high to minimize the risk of permanent pacemaker implantation.
Test.
We certainly adopted that in our
Vraiment,
practice
tu
in
vois,
Bahrain, that we look at it, we position
Pas du
it,
tout, on est hors
we take
valve,
an
tu vois.
REO view and look at and take a shot, look where we are in both medial and lateral, both edges of the valve before we deploy it. And then it does minimize the risk of pacemaker implant and decrease the risk of PVL in self-expanding valves as well.
Right. So do you have a, using that approach, the rate of pacemaker
Gigantesque.
need? Is there any data that, or what's your experience?
Well, we mean our numbers are not that big, but there is actually it was actually presented several times. There are some papers supporting that they think, as I recall, the rate of pacemaker came down to around 5% in certain series in which they use the cusp overlap views. Certainly it does. That came up, and this is where it adapted the change in some of the centers' practices with this change in just taking few views and being careful where to implant. And it did actually. There's some data about that, around roughly about 5%.
In such cases, with the patient got already a pacemaker, would that make a difference? Like would that make change your...
No, not really. I mean, it gives you reassurance because the patient does have a pacemaker, but there are other individuals in which some of them you can predict the chances of high pacemaker requiring post-procedure. For example, I mean, now we also do, for example, a Holter. Before one of the pre-TAVI workup that we do is we do a Holter and look if they have intermittent AV block, intermittent bundles and whatnot, and then you can be part of your consent with the patient that you may require. The chances of pacemaker is very high, and then these are the people we plan ahead of what to do and get the EP people on board. And when we implant during the implantation time, we have become very meticulous at trying to implant as high as possible, utilizing the advantage of the cusp overlap views.
Well, talking about the pacemakers, I don't know if any of you got an experience with the LV pacing. I mean, still we're using RV.
Ouais, j'arrive tout de suite. Tiens.
So the pigtail is giving you a bit of a challenge, correct?
And I also can't see the LV wire clearly.
He pulled it back. I think before deployment he pulled it back. The only thing is because it was low, pulling it back may make you go lower. Because the tension is reversed. But I guess we'll ask him. Let's see where we are now. So Dr. Lafont, now you're...
Yes,
Dr.
we decided to replace the valve.
So you're resheathing the valve?
At least we can see that the right ostium of the coronary ostium is fine. It's very difficult to replace. OK, test. Bon, écoute, on se met là, on est bien. OK.
You're going to re-advance your guide wire? Or is it still there? Yeah, it's still there. We just don't see it, actually.
Yeah, but just off the screen.
It's still there, yes.
Ouais. Test. Bon. Cochon de merde. Il va rien savoir.
I think it appears to still be low.
Tu sais qu'on a des calcifs.
Yeah, he's still trying to position his pigtail catheter to be sure.
OK, on est pas mal là.
Right now it's not clear how, as far as the level is concerned, the pigtail is not.
Unfortunately, the images.
And the images, yes.
Test.
Mais comment tu veux qu'on attend?
Bon, allez, vas-y. 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 Vas-y encore, vas-y.
Il a l'impression. Il faut vraiment mettre la pigtail.
Ouais.
Là, on va rien.
Pigtail, elle fait ce qu'elle veut, je veux dire. Tu vois, regarde là. Je la balade.
Vas-y, fais ce que tu dois faire avec l'injecteur.
On peut le... ouais, faites l'injecteur parce qu'on va en avoir besoin. On va rien savoir. De toute façon, je peux pas la mettre plus. Hein. Allez, hop.
Okay. C'est bon, Johan?
Bon, on a une pression à 12. OK. Test. C'est pas mal là, hein. Ce qu'il faut, c'est injecter franchement. Hein. Feu. Okay. Okay, what do you think about the next position?
That looks better.
Yes, that
It
looks
seems
better.
much better.
Yeah.
If it stays in this position, that's good.
Allez, on l'ouvre et on se barre. Ok. Attends, bouge pas.
Bon, on largue la
All the
valve.
panelists are happy with that position, Lafont.
Yes, all the panel is happy with the position. Okay.
Ok, vous êtes prêts?
So yes,
Ok.
je pousse.
Didn't move, eh?
Oui.
I mean, we don't see the images very clear, at least for me here.
Do you see the images?
The images are not very clear.
It's,
Okay, 1 and 2. Very good.
very good.
Okay, so it's deployed.
Ok, là,
That
on va
is-
essayer de... Voilà. Bon. Ok. Peut-être prendre un
I think
guide.
what's new to me is the fact
Tiens, tu me
that
passes un...
the wire. Dr. Lafont seems to use the device with no wire in the LV. Or I could not see the wire in the LV.
No, I
Yes,
think there was the wire in the LV. We didn't see it.
In fact,
I
the
thought it
wire
out.
was retrieved because it was inducing arrhythmia. And then I pushed it just before the...
So you re-pushed it.
Oui, on peut arrêter la stimulation.
For deployment.
Merci Yves. Non mais là il est beaucoup mieux quand on le stimule pas en fait.
Normally with the
Eh, il
Evolut
est à
system, you
180,
like the final deployment to pull back as much as you can, correct? What does the panel think?
Vas-y purge.
Pull back the wire, I mean.
Okay.
C'est bon, on voulait.
So now we will check whether we have to fight with a very severe regurgitation because of the calcification. Okay, feu. In fact, in terms of aortic regurgitation, we have, I would say, a grade 1. Est-ce que tu vois la coronaire droite? Oui. I see the two coronary arteries, the right and the left. And in fact, I'm not sure that we will need to get, so I may just measure the pressure. Si, il faut mesurer pour voir s'il n'y a pas un gradient. Non?
The question, Dr. Lafont, to you and to the panel, I guess, is, would you pull the wire, especially knowing
Yes, it's
that
very
this
good.
case is calcified with the risk of paravalvular leak and the need to
Yes.
Post-dial.
dilate,
Absolutely. I think
We need
we
one.
got a nice opening of the valve with a small balloon, and we are totally off-label since we should not put in valve in this size of annulus, but based on the bicuspid anatomy plus the very heavy calcification, in fact, the valve is staying well. And we were worried about possible aortic regurgitation because of the huge calcification on the left. But I mean, both the hemodynamics is fine because the diastolic pressure is 95, and also the angio is fine. So.
Right.
At this point, we were able to do a good job with the core valve 34. And does the panel consider that we should do anything like post-dilation?
Do you normally do an echocardiogram on the table? We still have the habit of doing this, and I'll be curious what the panel thinks about that.
No. In fact, what we do, in fact, is we do angio. And when we are not happy with the angio, we do hemodynamic. That is that we measure the gradient between the telediastolic ventricle and the telediastolic aortic. And we index it with systolic pressure. And when the ratio is satisfactory. We consider that there is no need to... It has been very well described in the GACC 8 years ago. Tu te souviens de l'auteur?
Just
But
a quick
anyhow,
question
this is
again.
what we
To
usually
do
do.
those hemodynamics, you need the pressure. Sorry, the catheter in the LV. Did your wire come accidentally out, or was it intentionally?
No. We do not. It was not accident. The wire is very arrhythmogenic, and we do not like to leave a wire. This patient has coronary artery disease. Is old, so there is. We do not want to excite involuntarily the left ventricle. What if we want to go back in the left ventricle? It's not a big deal.
Or testing for any regurg or.
On va changer avec le.
You recross if there is something.
Yeah, normally we leave the wire in, put the pigtail back, measure the gradient, make sure also that the diastolic pressure is not that low, get an echo on the table. We take some extra minutes to do that, but it's not necessary. As you can see, Dr. Lafont doesn't, if he's happy with the angiogram, he's happy. And you can recross if you want, but what do the rest of you do to make sure about the result? Do you go back with a pigtail to measure pressures? Do you keep the wire in? Do you do an echo? I'd be curious to see what you all think.
Ziad, I could take that. I mean, I could tell you, we shouldn't have shortcuts. I know as we do more of these things, we get more comfortable with what we do and what we don't do. But, these are typically, they're difficult cases, higher risk cases that, and you invest a lot in them, even from economical standpoint, and not let alone the outcomes. So, I mean, in our practice, we don't take any shortcuts, not from the access, not from the before implant. We do all hemodynamics before. We do the whole hemodynamics after. We do the echo.
Est-ce qu'on peut faire des 2-0 et donner une autre voie veineuse, une autre voie de pression?
Like in any field in interventions, we get the confidence, and we sometimes skip some steps. In our cath lab, we have decided with the TAVI group that we have steps that we put in. It's like the pilot when we take off and we land. We do the checklist all the time. All the time.
Thanks, Hassan. Saleh, do you do the hemodynamics and the echo on the table?
Vas-y, repurge.
We do angio plus minus hemodynamics.
Bon.
The hemodynamics not routinely.
Voilà.
We do.
Est-ce que vous pouvez mettre l'écran sur les pressions, s'il vous plaît, Monsieur Trio?
The deciding factor is really the transthoracic that is done in the room, if we're going to post-dilate or not.
And how
we have the hemodynamics up there.
No.
Okay. If you want to see the screen,
Yes.
on a vraiment fait les zéros parce que la PTLVG est très élevée.
Si vous avez bien fait les zéros sur les deux.
Those are nice hemodynamics.
So they have
Okay,
a
at
very
this
good
point,
hemodynamic result.
We can see that there is it's a satisfactory
gradient,
hemodynamic both on the
60.
systolic and the diastolic. Yes. We
Or actually 80 diastolic.
reset the zero
VVP seems a
pressure.
bit high, but
Non, là, bougez pas.
Yeah, so that's very good.
Great hemodynamics.
I think this is the biggest size in the market. Il a 80, mais le
With
PTLVG est
that
très
calcium, you would expect, you get
Avec il a moins de 80, il a 70. Avec un peu plus de 40 et une systolique à 200.
Ouais. Ok.
Vraiment trop bas.
So Dr. Lafont, what do you think?
Okay. I think it was a little challenging because bicuspid, because of a very high level of calcification. Our colleague was right about the coronary ostia that we had to check, but we have a very good Valsalva deployment. So we did not have a major deregurgitation after the first predilation. we consider that the valve was not very suboptimally placed on the first try, and that at this point, having said everything, we can still consider we can improve the situation, but I think for this gentleman there is basically no aortic regurgitation. And also with the core valve, we will have still an expansion during the hours, following hours. And usually when we find this type of aortic regurgitation on the table, during the evening at the echo in the ICU, there is no more aortic regurgitation. Unfortunately, the patient has already a pacemaker, so I cannot tell you whether we were harmful in terms of the conduction. But so hopefully this patient will go tomorrow in his room, and after the weekend he should be at home.
Great case. Just going back to the,
will finish,
that's great, Dr. Lafont. The osteal RCA stent, if you did have some protruded struts, would you have intervened differently, especially with the, with the catheters and instrumentation in the aortic around the, and the right coronary, having the pigtail and all this hardware? Would you have wired it and then taken that stent, especially with the recent stent?
Mais le prostar c'est trop tard, non?
Non, c'est le montant.
Oui.
Mais on n'est pas obligé de le monter.
We will now retrieve the device, and we will close with the new system for us. I don't know if you know it. It is called the MANTA system. Who knows that system?
We don't have it.
Pardon?
I mean, I know about it, but we don't have it. It's typically it comes in 14 to 18
MANTA is a
French,
system which is able to go to close until 24 French. Okay. If you can see the device, so this is a device that will. It's a little like angioseal, in fact, except that there is a system which will make a knot to withdraw prevent the possibility for the collagen to leave. And so this is a delivery system. We do the work of the MANTA guy because he is not here. We have no financial relationship with this, but we consider to replace for us a ProStar. It's a great device. So we will first retrieve
the 15 or the 18.
C'est quoi ça comme ça size? It's a 14 French.
Okay.
In fact, it is. Sorry, it is 18.
You would not
18 French.
consider the MANTA?
Attends. Cases we would not. It is still all. There is no zero risk system. Okay. We have. Alors comme c'est un peu couillu. Ah oui, est-ce qu'on va réussir? Ah oui, c'est con, on aurait dû laisser le guide. Parce que est-ce qu'on va réussir à mettre le MANTA à travers l'arrière?
Oui, c'est compliqué. De toute façon, le guide il est en place.
Oui, le guide, oui, mais on aurait peut-être dû laisser le.
De stick, on peut pas faire un montage.
Ah bon?
Non.
Alors, Mohamed, tu es prêt?
Panelist uses the MANTA.
We don't. We still use per close. And it would be really insightful to see if he's noticed any difference. What we have done in terms of axis is we abandoned the non-tabby axis. So the non-tabby axis, we go radial 100% of the time. So we only have one femoral axis. And the pacemaker, we either put it through the antecubital vein or through the neck. Sometimes through the femoral vein if there is a short neck or for other reasons. But in the groin, we only have one stick, which is the tabby side.
Great.
Oh. Okay.
So,
donc là,
Lafont,
okay.
It would be great if you can explain to us all the steps you're getting
On peut nous montrer le. Ok.
Jusqu'au bout.
Voilà.
Bien vous enlevez le bleu en laissant le guide en place.
C'est fini, monsieur, on en retire tous les petits tuyaux. Là. Bon, là, il faut pas faire de merde. On n'a pas foutu le guide en face et on avait une merde. Voilà. Est-ce que vous pouvez montrer, regardez. Oui, So we just put the wire into the Manta system. The sheath Manta is already in the artery point. Okay, you can see. Ouais. Ok. Et là. Voilà. Double clic. Maintenant, il faut faire 7. Il faut 6 plus 1.
Donc là, il faut monter à 7 avec 45 degrés.
Okay, so I go to 1 centimeter more.
C'est bon.
Okay, and I have to very absolutely to be 45 degree. Et maintenant, hein?
Oui, tournez ça.
And then when I am on the 7 and 45 degrees, I just put this little blue stuff.
Arrêtez la copie. Ok, non, là, vous sortez à 45 degrés jusqu'à l'ovaire.
And then
sans appuyer, là.
I have to withdraw until the screen. And then...
Non, vous êtes ouvert?
Oui, je suis ouvert. Si. Là, je suis rouge.
Ah, ok, c'est trop tard. Ok, avancez le bleu en laissant ça en tension, sur le rouge.
J'avais fait le clic.
Ouais, je l'avais pas entendu.
Ok.
Après, vous êtes au rouge,
ouais.
en contact de l'artère, 10 seconds.
I am waiting for 10 seconds. In fact, this system is like angiosyle. You have an anchor, you have collagen spot, and then this blue stuff is making a little knot, which is preventing the displacement of the collagen. And then I can release the right hand. I retrieve the blue stuff, and you can see that. In fact, can you make a zoom on the... Okay, here is a point. There is this is over. So now we just do an angio control. It's really very nice.
Yeah.
We were ProStar lovers, but since one told us that ProStar is no more.
Do you do any contralateral injection to have a look at the...
Absolutely. I mean, we are very confident, but the best way to be confident is to... Attends, si. Plaisante.
And I want to ask the panel, do you all do contralateral at the end?
I do.
Yes, I do.
We don't, only if we're concerned. But we check.
Okay, so we are.
Ok, on va se mettre 10 à 5.
10 à 5?
Ouais.
Ok.
So you're in the contralateral then.
Ouais. Qu'est-ce qui se passe au niveau de l'écran là? Vous voulez faire en soustraction ou pas?
Comme tu veux. Je m'en fous. Si tu veux. Hein.
Non. Stopping, pour voir où est-ce qu'on est.
On est... Okay. So the system is still in place. We can now fire. Okay, there is a little still something else which needs maybe. Est-ce qu'on pourrait faire la protamine? Marc, il a. C'est pas nickel. Hein. Qu'est-ce qu'on fait? On met un dose.
On va comprimer un peu.
Ouais, dose pour dose, ouais.
Je pense que je vais mettre un stent.
Comment?
Peut-être demi-dose parce que si jamais il faut poser un stent.
Demi-dose, ouais.
Contrast, is there an extravasation?
As you can see, there is a little pitch, and which needs. But the wire is still there, as you can see, and if we are not totally happy, we can put a stent.
So what you're seeing is really that the plug did not take it all the way, correct? That's probably...
The plug did not do totally his job.
Yeah, so how about just compressing? How about compression for like 5 minutes and repeating the shot?
No, absolutely, I totally agree with you. This is what we intend to do. In fact, we will do a compression for 5 minutes, and then we will see.
Yeah. Well, that was a great case.
Great.
And what you have not seen, I'm not, to tell you the truth, I'm not very astonished by the picture that you saw. Because in fact, just before we started, we had some problems because the sheath could not go very smoothly in the artery, femoral artery, and we had to fight a little. And we had to change the wire with a very stiff wire in order to position the sheath. So I think this is not the fault of and at the very beginning we were even afraid that we might have dissected the puncture point. So I think there was a little dissection, and this is now covered.
That's great.
Qu'est-ce que vous faites là?
Donc, ça peut partir jamais pour mettre un stent couvert.
The access protocol that you're following, I don't know if how the other panelists or the Lafont, what kind of access protocol do you use? I mean, we still use femoral access for most of the, the arterial and the pacemaker, but it's interesting to hear from the rest of the.
So we use ultrasound 100% of the time. All access is done with ultrasound, and because we only use, like I said, single point, we get to choose from the right or the left. If we're concerned, we take a final angiogram. Our vascular surgeons are also very good and nice. So any complication that we have a very low threshold for turning and post-procedure, doing a cut down for any sort of complication. So if there is any issue, the vascular surgeons are really happy to be in the room and do it in the room.
Ziad, do you still use femoral arterial access is both, you for the valve and the other groin you use it, or
yeah, normally a right radial and the groin. So normally we put the pigtail through the radial, and if not, it would be the other groin. And we follow what Dr. Saleh said, ultrasound guide to begin with, and it's very important to analyze the CT to begin with. For any calcification around this, the entry point, because that could be problematic at times.
Dr. Lafont, just
you
before
totally right. I agree with you.
We got a minute or so to finish. I think this is a great case, insightful, a lot of learning. Do you have anything to say before we come to the closure?
Est-ce que vous pouvez nous mettre juste la caméra pour qu'on leur dise au revoir? Oui, enfin sur nous trois, hein, voilà.
Dr. Lafont, can you hear us?
Okay.
Yeah, Dr.
Yes,
Lafont,
we
we're
hear
coming
you.
to the closure. We got a minute or less. Do you have any
Wonderful.
comment before we close?
At this point, we have no comments. The principal objective was successful, but in this patient, which is 100 kilograms, even with echo Doppler, in fact, we did not have any problems to find the artery. The problem started when we went from the 6th French to the 9 French. And then at this point, it was difficult to position, to help. And then we had to go with a very stiff wire, as I said. So I agree that echo maybe when you have problems to find, but and I agree also that the check of the CT is absolutely critical, not only the size but also the anatomy. But in very old patients, CT scan may underestimate the difficulties of the femoral, and I would advise that to use a very good echo Doppler to be sure that in fact the arteries are not worse than shown by the CT.
Great, very insightful case.
Otherwise, the patient is now sleeping, is awake.
Sorry.
Je crois qu'on peut faire un test là.
Thank you,
Thank you
Dr.
so much, Dr. Lafont. Very well done.
Thank you.
Thank you.
Thank you.
Thank you all.